Well, welcome everybody. My name is Lori Hartwell. I'm the president and founder of Renal Support Network. And we're very excited to offer this webinar series to help educate you further about your illness and how you can better navigate and care for yourself. I've been a patient since 1968 for a little over 50 years, since I was 2. And I can tell you for certain that navigating this illness, learning how to navigate it, what questions to ask, really empowers you to take care of your illness. And as a result, I'm still kicking. I like to refer to myself as a kidney warrior because you have to have a little fight in you to be able to survive this illness so you can get the best care possible. Today, we're going to be learning about the new frontier of genetic testing and kidney transplantation. And we have 2 presenters. So I'm going to go ahead and introduce both of them, and then I'm going to let them take it from here. So first, we have Dr. Gautier. Is that correct? Did I say that right?
Yeah.
AKA Dr. Phil. He is a transplant nephrologist and medical director at Natera. Prior to his time at Natera, Dr. Phil was the director of transplant nephrology at Tulane University and Centura Transplant Program. He has spent over 20 years treating and introducing the latest innovations to kidney transplant patients. So thank you, Dr. Phil, for being here. You're one of the pioneers in transplant. So you and Cher's kidneys are about the same age in kidney here.
Yeah, well, thank you, Lori, for the introduction, and thanks so much for inviting us here today.
And for those of you who didn't hear earlier, Cher, who's one of our, who works with RSN, she's getting ready to celebrate her 22-year kidney anniversary. So it's so important to do everything you can to maintain and keep the gift of life. We also have Trudy McKenna, who is the Director of Medical Education for Organ Health at Natera. Trudy is a certified genetic counselor and has over 15 years of clinical experience in prenatal, pediatric, and adult genetics, and 7 years of laboratory and medical education experience. She's a graduate of the University of Michigan and genetic counseling program, and is also a past president of the Michigan Association of Genetic Counselors and a former instructor at the Michigan State University College of Human Medicine. Welcome, Trudy, and maybe later we can talk a little bit about the Genetic Detective. I watched that TV series and really loved it. So please welcome everybody. I'm going to turn it over to Trudy.
Great. Thank you so much, Lori. And thank you to the entire group for having us today. It's a real pleasure and an honor to be able to speak to you. As Lori mentioned, most of my career to date has been in direct patient contact, direct patient care as a genetic counselor. And about 7 years ago, I left to join Natera because I really believed in their philosophy of, the education has to really start with the providers to understand genetics so that they can also educate patients and educating patients, and that there's this real philosophy of transmitting that knowledge to people. So I really appreciate the opportunity to get back to my roots a little bit, talk to patients again, because it's been a while. So what I wanted to do is really just start and lead into Dr. Phil's main presentation with just a background on genetics and why we care about genetics when it comes to kidney disease. And what's interesting about how Natera actually got into the genetics of kidney disease was we almost kind of stumbled upon it with another test that we were putting out about a year and a half ago now, for transplant rejection monitoring. And as we were talking to nephrologists, we kept getting the same question over and over again. Well, you're a genetic testing company. Do you have a genetic test for chronic kidney disease? And we kept hearing this question over and over again. And we talked to more doctors, we talked to patients with kidney disease, and realized that there really was this unmet need. And there really was a lot more interest in the genetics of kidney disease that was starting to become more and more prominent over the last couple of years. And we felt like we had a really good position to offer, a really good way for patients to get kidney disease genetic testing that wasn't available 5-10 years ago. So I'm really excited to be able to tell you more about that today. If we can go to the next slide.
I'm running the poll for you right now. So we'll leave it
Oh,
open.
should we give it a
maybe
minute,
more seconds.
Ellie, to finish the poll? Are we good? Okay. All right, let's go to the next slide. Okay, so why do we care about the genetics of chronic kidney disease? You know, you have a diagnosis of kidney disease, perhaps, or somebody in your family does, but why does it matter if it was a genetic cause or if there's some other cause? Well, we know for first that chronic kidney disease is a very common problem, you know, globally, not just in the United States, affecting more than 10% of the entire world's population. So it's a huge public health issue. About 25% of patients with chronic kidney disease have a family history. And this gives us an opportunity to maybe, you know, identify people before they're symptomatic. Can that help us with their disease progression? Can we slow the disease progression if we know earlier, if we can look at a family history? Also, if we look at, you know, the earlier the age of onset of chronic kidney disease, the more likely it is to have a genetic diagnosis. And so if you look at pediatric kidney disease, most of it has a genetic cause. But sometimes what we've noticed is, you know, over time, if the onset of kidney disease becomes in adulthood, people don't think about genetics as much. And we really want to start having providers and families start thinking about genetics, no matter when you develop kidney disease. And this statistic is very, you know, fascinating to me. 1 in 10 patients diagnosed with kidney disease can have a genetic etiology or a genetic cause for their kidney disease. And that risk is much higher the earlier the age of onset. So going back to this pediatric kidney disease, and if you have a family history, that risk can be quite high, actually, that somebody's kidney disease can have a genetic etiology. So this is a very common problem. And the more we know about why somebody has kidney disease, is it genetic? Is it non-genetic? If it is genetic, what is causing it? The more options there are to hopefully treat those symptoms in that disease. Next slide. So just a quick genetics overview. This is something that, you know, is part of, if you have any kind of genetic counseling appointment ever, this is kind of the basis of, you know, what are we talking about when we're talking about genetic testing and genes. So this is human body. Every body is made up of billions of cells. And in the cell are all of your chromosomes. And those are stored in the nucleus. There's 46 chromosomes in every cell. I kind of think of a chromosome as like a recipe book. So there's essentially in every single one of your cells, 46 recipe books that have all the individual genes or recipes that tell you who you're going to be. It's telling that brain cell to be a brain cell, a kidney cell to be a kidney cell. And the way that those recipes are read is by your DNA. So your DNA is it's like the recipes. Every individual recipe is called a gene. There's probably about 30 or 40,000 genes that make us who we are. And everybody has a little bit of variability in their genes that make us all different. And most of that variability is fine, but sometimes you can have a spelling mistake in a gene. And that gene then maybe doesn't function the way it's supposed to. And if you're kind of keeping up with the recipe analogy, say you have a recipe and it says add 3 cups of flour. And then instead of that saying 3 cups of flour, your recipe has a mistake that says add 30 cups of flour. Well, your end result isn't going to look exactly like you're expecting. And that's what we're looking for when we do genetic testing are all of the genes spelled correctly? We're going to look at certain genes, we're going to pull those out, look at the spelling and see, are there any spelling mistakes in, say, an Alport gene or a Gittleman syndrome gene or something that makes that spelling of the gene incorrect that could then lead to genetic disease. Next slide. So here's our genes.
Sorry, I missed that one.
The animation kind of, it's fine. And why do we want to look at how a gene is spelled? It can tell us a lot about what's going on in a family. So remember the couple slides ago, 25% of all kidney disease has a family history. And it's really important to understand what's the genetic cause in that family, because the inheritance pattern or how that's passed down through a family is really dependent on what's going on, what the genetic results are. And there's a couple different ways that you can inherit different genetic conditions. X-linked conditions where a woman carries that gene, in general, they tend to be less severely affected than boys who carry that gene, but not always. We're learning a lot more about that the more genetic testing we're doing. Autosomal dominant testing, where the parent has the condition, there's a 50% chance that every child could have that condition. So this is when you tend to see a strong family history, like autosomal dominant polycystic kidney disease. It's in the name. Or autosomal recessive, where parents are healthy carriers And then, but if they can pass that gene on, then their child can be affected. In these families, we tend to not see a whole lot of affected people because they tend to be more rare. So it's really important to understand what the genetic cause is, because then we can identify who might be at risk to develop this condition, who's not at risk. One of the things you'll see that isn't listed on here is, genetic conditions don't skip a generation. That's probably one of the most common questions I would get as a genetic counselor is, well, I think my disease skips a generation in my family. And it's very easy to see when you look at a family history why it could look like that, because there's a lot of times where somebody could inherit a genetic, the gene, but they are just more mildly affected. And so they don't even kind of come to medical attention because their symptoms are so variable, their symptoms are so mild, unless you're looking for it, it can go undiagnosed. But then they say have a child that's displays symptoms at an earlier age or more severely. We would see this in our genetics clinic, not infrequently, where we would diagnose a child with a condition and look at the parents and say, actually, now that we're looking, we see some symptoms. So this is kind of how that knowledge of how the condition is inherited in a family can really help understand what's going on in a family. Can also identify, even if somebody has mild symptoms, are there things that they could be doing to improve their health? Are there other family members who could be at risk, or that maybe are worried that they're at risk, that we can reassure them they're not at risk for kidney disease? I think that's the next slide. I think I'm going to turn this over next to Dr. Phil, who will talk a little bit about, kind of expand on some of the things I introduced now about what the real benefits are of doing genetic testing.
Thanks, Trudy, and thanks again to everyone for attending this session on a Saturday morning / afternoon, depending where you are. It's been my great honor and privilege to provide care for patients with chronic kidney disease and kidney transplantation for over 20 years. It's obviously very important for doctors to help treat and cure patients, but equally important, I believe, is our role as teachers. In fact, the word doctor comes from a Latin word that means teacher. And I've always enjoyed the teaching aspect of my career, probably more than any other part of it. So I definitely feel like today is an extension of that. And I also feel that one of the great benefits of genetic testing is teaching. It teaches patients what's causing their condition. It helps them understand the condition better. And I think we'll all agree that the fear of the known is much less than the fear of the unknown. That's not always completely rational, but there's certainly something to be said for knowing what condition you have and what you can expect in the future, even when there is no actual cure. So we have a renal genetics panel called Renasight, and we will tell you much more about that in the next few slides. But for now, I just want to go through some of the reasons that we introduced this panel and why this panel is so important for you. There was a large paper in the New England Journal of Medicine, and Trudy mentioned this earlier, but it showed that if you take a broad group of patients with just any kind of chronic kidney disease, that 1 in 10 or 10% will actually have a genetic diagnosis. Now, more importantly, for the patients that did receive a genetic diagnosis, fully 89% found that this diagnosis had implications for their clinical management of their disease. And in particular, understanding the genetic cause of a kidney disease can help you know how it's going to progress. Is this going to progress very quickly and you might need a transplant or dialysis in a few years, or is this something that's going to take decades before it becomes clinically meaningful? It's also very helpful to gain personalized insight and guidance into medication, treatment, and clinical trials. Now, one of the myths that I hear often is there's no treatment for genetic disorders. That's not true. Increasingly, we are developing treatments for genetic disorders. This is still in its infancy, but it's progressing very rapidly. In fact, there are now over 100 clinical trials that are associated with the genes on our panel. And it won't be too many more years before genetic disorders can routinely be treated. Often a genetic diagnosis will also help a patient to understand what medications they may need. Some of the genetic disorders can be treated with conventional medications, and you can also better understand what medications might work better for you compared to other patients who have a similar chronic kidney disease that's not genetically based. And in some cases, it will tell you what medicines won't work and you shouldn't take. And then finally, one of the great benefits of genetic testing is that can help your family. It can help your family understand their risk factors for kidney disease. It can inform them that they need to undergo certain lifestyle modifications that can promote good kidney health and may potentially defer the development of chronic kidney disease in those family members for decades and maybe never. So there's a lot of benefits to earlier diagnoses. And if a patient has a genetic test result, they can then talk to their family about it. And perhaps many or most of their family members will also undergo genetic testing because, as we all know, identifying a disease earlier is always better. Okay, so now I'm going to share with you a video, and they say a picture is worth 1,000 words, so I guess a video is probably worth about 1,000,000 words. So let's roll it.
The Renal genetic test provides a more complete picture of your kidney health. It can help you understand if there's a genetic reason for your kidney disease, or if you may be at increased risk due to your family history. Approximately 1 in 10 cases of chronic kidney disease is genetic, and identifying the responsible gene has a direct impact on treatment. Genetic testing can help in many ways, including identifying the underlying cause for your kidney disease, the risk of progression, provide guidance on effective medication, and the need for referrals to other specialists. Renal is a comprehensive test that analyzes over 380 genes associated with kidney disease. It uses next-generation sequencing, an advanced technology that delivers greater than 99% detection rates across the gene screened. Renal results show whether a disease-causing or likely disease-causing variant has been detected for a specific condition. A variant is when a portion of a gene appears different from the expected appearance. Knowing this information provides valuable information for your care. Once your physician determines Renal is right for you, the testing process consists of 3 simple steps. 1, your physician orders the test. 2, you provide a blood or saliva sample. Natera can schedule a blood draw specialist to come to you or ship you a saliva kit. 3, results will be ready in approximately 3 weeks. To ensure you have all your questions answered about the test and its results, Natera provides complimentary information sessions with one of our board-certified genetic counselors. We understand cost can be an important factor in your decision-making, which is why Natera is committed to making the Renal genetic test accessible for all patients. We welcome all insurance plans and provide affordable testing through a variety of payment methods, including discounted self-pay pricing and financial assistance through our compassionate care program. Discover more about your kidney health, choose Renal, and learn how it can help inform treatment strategies.
All right, well, back to our presentation. Thank you. So that was a great video. So there are several questions that we can ask to determine if you're a candidate for genetic testing. Now, probably everyone who has chronic kidney disease could be considered a candidate for genetic testing because you never know. However, there are certain features of chronic kidney disease that indicates it might even be more important for you to have genetic testing. And the first question is the most obvious. Do you have kidney disease of any type? And if you do, you may benefit from genetic testing. Again, up to 10% of patients in a large group of patients with all types of chronic kidney disease did have a genetic diagnosis when they underwent broad-based genetics testing. In particular, the next question is important because many patients have unknown reason for their chronic kidney disease. So if a doctor has ever told you, hey, you have chronic kidney disease, but we're not sure what's going on, you should definitely get genetic testing because in that same paper that we've been talking about, 17% or 17 out of 100 patients who didn't know why they had kidney disease actually received the genetics diagnosis and now they had an answer. It's also true that if you have protein in the urine or blood in the urine, that you're more likely to have a genetic cause of your kidney disease. If you have cysts on your kidneys, you're quite likely to have a genetic cause of your kidney disease and should definitely get tested. Same thing goes if you have structural kidney disease that you were born with. So if you were born with kidney disease, you probably already had genetics testing at this point, honestly, but if you haven't, you should run, not walk to your doctor and get a genetics test. And then finally, if you have any family history of chronic kidney disease, you're far more likely to have a genetic diagnosis. In fact, up to 1 in 3 patients who have a family history of chronic kidney disease will have a genetic diagnosis when they undergo testing with our Renal panel. So let's go do some cases. And I think it's always helpful to present cases to illustrate the power of genetics testing. And these are real cases that we saw at Natera. The first case is, and of course the names were changed. The first case is Jacob, and he's in his late 20s. And he was evaluated for what we call nephrotic range proteinuria. That means you have lots of protein in the urine. And the way I explain this to patients is, your kidneys are filters, and they let all the junky stuff go into your urine, but the good stuff that you want to keep in your body, like protein, is supposed to stay in your blood. However, when the little filters start to be damaged by disease, they start to break down, and the protein can leak out of the blood into the urine and can then be detected with a test. And this is a bad sign because it means your filters are leaking, and that is one of the earliest signs of kidney disease. So this patient actually had lots of protein in his urine, which is not great. He didn't have any family history, so he had a kidney biopsy, and this showed a disease called focal segmental glomerulosclerosis. If you can say that 10 times fast, you will be an honorary nephrologist. We abbreviate it as FSGS. He was given two different kinds of medications. One is called prednisone and one is called Acthar. It's actually a ACTH. It's a hormone, and it's made as a gel. It's also extremely expensive. So I don't know what this guy's insurance coverage was, but I hope it was good, because prednisone is cheap, but Acthar is very, very expensive. Unfortunately, neither of the medications worked. His kidney disease kept getting worse. So he decided, or his physician decided, that he should have a genetics test. And this was important because it would clarify why he had this disease, FSGS. It would help him understand if he would respond to medications or not, and would also give him more information on whether this would keep getting worse or whether it may go away on its own. So he had the test, and he did have a certain gene. It's associated with a connective tissue called collagen that's in all your tissues. It's also associated with a different kind of kidney disease called Alport syndrome, but it can also be seen in patients who have FSGS. Now, this was very important for him because one thing we know is if you have FSGS and you have this gene, you're not going to respond to treatment. So he could have saved a lot of money by not having that Acthar, and it would have been great if he had had this test before he went through all that. And also, although the prednisone is cheap, it does have a lot of side effects. So now he knows he doesn't need to take any of those medications. He also knows that unfortunately he is at high risk for kidney disease progression. So he can start thinking about getting a transplant early, start identifying potential living donors. I guess if you were cynical, you could say he could start being really nice to his immediate family members so he could butter him up and be ready to ask him for a kidney transplant in a few months. But the good news is that when he does get a kidney transplant, it's very unlikely that this FSGS will come back, because in other types of FSGS, it can actually come back very quickly after a kidney transplant, even within a few days. And the kidney transplant can fail. So he knows now that he doesn't have to worry about that. He also knows he doesn't have to take special medications after his kidney transplant to prevent that from happening. He also now can talk to his family about this and tell them, hey, they may be at risk for this. And considering how young he is, any of his family members should probably get tested as well so they know what to expect. And finally, many patients who have this gene also have problems with their hearing and even their vision. And this can be difficult to detect. So now that he has this diagnosis, he can be referred to an audiologist and an ophthalmologist or optometrist and can get this checked on early before it gets too severe. So this was a very beneficial test for him. It would have been even better if he had gotten it done earlier in his course of disease. So the second case is Angela. She's in her late 50s, and she already had a transplant, but unfortunately her transplant is starting to fail. And she actually had two kidney transplants. So the first one failed very quickly, and the second one is starting to fail. She also has difficult to treat anemia, and she has a brother with kidney stones. So they decided to do a genetics test for several reasons. One, they wanted to explain why her white and red blood cell and platelet counts were going down, but also they wanted to understand why her first kidney failed and what was going on with her second kidney. So she had the panel, and she was discovered to have a variant in a gene called CFI, and this causes a disease called atypical HUS. FSGS stands for hemolytic uremic syndrome. Basically, your red blood cells break down and your kidneys fail. So it can cause anemia, low platelets, low white blood cell count, and kidney failure. Now, there is a treatment for this disease. It's called eculizumab. And if she had known that she had this disease, they probably could have given her treatment after her first kidney transplant, and she wouldn't have needed a second kidney transplant. Now that she knows this, her second kidney transplant, she did receive the treatment and her kidney transplant function stabilized, and she did not need a third kidney transplant. So this was a very helpful diagnosis for her to have. And again, the only problem here is it wasn't done soon enough. Although, honestly, we haven't had easy access to genetic testing till recently, so it probably wasn't available for potentially either one of these two patients that I discussed. Now, we've talked about one of the benefits of genetic testing, that is testing at-risk family members, and we call this the power of knowing. And we've already said that 1 in 10 patients with chronic kidney disease can have an underlying genetics cause, and that if you know this risk, you can talk to your family members and they can have a proactive plan to avoid chronic kidney disease, or at least treat it at an earlier stage. And again, it's always good to treat diseases at an earlier stage. It's also very important for kidney transplantation because current guidelines do recommend that if you have kidney disease and a relative, a first-degree relative, wants to donate to you, they should undergo genetics testing to make sure that there's not a genetic cause of the kidney disease, which would mean that if they donated, they would be at extremely high risk to develop chronic kidney disease later in life. And we certainly don't want anyone to donate their kidney if there's any risk that they're going to have kidney failure later on. So it is important to test potential living donors when there's a family history of kidney disease. We don't necessarily recommend testing all donors, regardless of family history, but certainly if there's a family history, it is important. And there's a patient advocate, many of you probably know him, Dwight Odland, and he wrote an editorial in See Jason towards the end of last year, and he was talking about how important genetics testing is. And he's talked to many patients who were diagnosed with polycystic kidney disease, which is a genetic disease. But most of them only found out about this once their kidneys were already severely impaired and they had many symptoms. And of those patients, the vast majority wished that they had known sooner, that they had genetics testing when they were younger, because they could have avoided certain health practices that can actually accelerate kidney disease. And that includes things like drinking water instead of soda, avoiding excess consumption of high protein supplements or energy drinks, avoiding medications that can damage the kidney, such as non-steroidal anti-inflammatory drugs like ibuprofen and Advil, avoiding potentially dangerous contact sports, and taking mild elevations in blood pressure seriously. You know, if you're 25 and your blood pressure is mildly elevated, the vast majority of the time your doctor is not going to recommend any treatment because they're going to consider that it's what we call white coat hypertension, meaning that you're nervous around doctors. Or they might think since you're so young, it's not that important. But if that same patient knows that they have a gene that's associated with kidney disease, the doctor is much more likely to take that seriously and to recommend treatment. So there's multiple advantages to knowing that you're at risk for kidney disease at a younger age when you can make a serious effort to change your lifestyle and avoid unhealthy kidney habits. And this is what patients want. So at this point, I'm going to turn it back over to Trudy, who can tell you exactly how to get this test ordered for you or your family members.
All right, thank you. You know, some of the things we heard pretty consistently before we launched the Renal test were that providers really saw the value in doing this for their patients, just for all the reasons Dr. Phil just mentioned. You know, they really felt that there was a lot of medical use in doing this, and families wanted it. But there was two real concerns that they had, and Natera spent a lot of time figuring out how to best meet those needs. So the two concerns were cost and ease of use and understanding that the genetic information. So the next couple slides will kind of talk about how we've built a lot around those two barriers to really hopefully remove as much of those barriers as possible so that people who want and need genetic testing can get it done. So the way that this can be ordered is very simple, even in COVID days. It does require an order from your physician. So this isn't a test that a patient can order. It's not like a 23andMe or something like this. This requires a physician order. And then Natera will send a kit. It can go to your physician's office. You can have your blood drawn in the office or the hospital. It can also be a blood kit, a saliva kit that goes to your house. So it's, especially during COVID, we've seen a lot of people get this kit sent to their house, or even in the office if they don't want to have blood drawn, or if they have some issues with having blood drawn. You can even just do this with like a cheek swab saliva kit. So very easy collection. As was mentioned earlier, the kit then goes to Natera. They process it. Genetic testing can take a little bit of time. So in about 3 weeks on average, we get those results back. They go to your provider, and then the provider will contact you and share those results over the phone. Typically, sometimes they will also schedule an appointment with you. It really depends on how your provider prefers. But the initial results will come to you from your ordering physician. Next slide.
Sorry. Come on, there it goes.
There you go. So one of the things, like I mentioned, that was a concern from both providers and patients is there's not a lot of time to make sure that you're up to speed on all of the ins and outs of genetic testing. And some of the terminology can be very, unique to genetic testing. And we want to make sure that both the providers and the patients understand their genetic test results, what it means and what it doesn't mean. So providers have access to our board certified genetic counselors before they order a test, after they order a test, before they call you with the results, so that they, can walk through those. And patients also have the ability to talk to our genetic counselors at any time. So this is part and parcel of any Renal test. Is we welcome conversations and questions from patients to the genetic counselors before you have the test. There's a lot of questions. Should I have this test? What about insurance questions that I have? Here's my family history. Should I have the test? Should I start with my mom? These kind of things about is it now the right time? These are all kind of the test questions that happen before testing that a genetic counselor can talk to you about. These are usually about 15 minutes. They do have to be scheduled in advance. They can usually get you in probably within a day or two. And then if you decide to have the genetic test results, they come back, then this is also still included in, there's no charge to any of this. A 15 to 30 minute post-test consultation is also available with a genetic counselor to review your results. Okay, so I have this result. What does this mean? Who else should get tested? Or I got a result back and it didn't give me the results that I was expecting, or it was negative. What does this mean? There's a lot of different reasons why you may just want to check in with a genetic counselor. We want to make sure that we have that available to you. Sometimes there may be some more complicated issues in that, or a stronger family history that can't be addressed in these, pre and post test genetic counseling sessions. And the genetic counselor at Natera can help, find a genetic center in your area or get you plugged in back to your provider. They also send a note to your provider. So that's kind of all in this nice little package to say, we've addressed these questions and hopefully answered your questions about that. Next slide. So that's kind of the access to genetics. The second was the cost. When I was in practice, we honestly didn't do genetic testing for kidney disease. And I think a lot of people really haven't looked at doing genetic testing since that time. For example, probably 10 years ago, maybe a little bit more than that, a genetic test for ADPKD could be $6,000 to $8,000 and have a terrible detection rate. So even if you got a test result back, it didn't necessarily mean that you could even pick up everything in that gene. It really wasn't a good use of time and money. So honestly, we didn't do it a whole lot. The technology in the past 5 to 10 years has completely revolutionized what we can do and how well it can be done and how cheaply it can be done. So it's really a whole new world of genetic testing. And that cost savings in doing the test also is passed down to the patient. And Natera really has built a system around making sure that everybody has access to the types of tests that they should have. So if you have commercial insurance coverage, Natera will estimate your out-of-pocket cost. If it exceeds $349, so you have a high deductible, you can pay $349 as a cash pay price and just out of pocket and be done with it. So the most you would ever choose to pay is $349. You may choose to meet your deductible if it's January and you're going to meet it anyway, but they'll give you that option. So going into it, the most you'll ever pay is $349. But there's also compassionate care programs where based on certain criteria that you have to just notify our billing office about, they can reduce the price of genetic testing between $0 and $149. So we have a whole other department in billing that is available to review those options with anybody who is interested in testing. If you have Medicare or Medicaid, this is completely covered. We accept whatever payment we get from Medicare and Medicaid, and we never balance bill a patient. So there is absolutely no out-of-pocket cost to anybody with any government insurance plan. Next slide. So I think that wraps up our presentation, and I think we're going to questions and Q&A now.
Yes.
Is that okay?
We have 12 questions. So,
Okay.
so our first one is from Bridget our first one is from Bridget H. My husband was diagnosed with IgM nephropathy. What exactly is that?
Well, there's a more common one called IgA nephropathy, and IgM is very similar. And it's basically, IgM is a type of antibody. So IgM nephropathy is a disease, it's an autoimmune disease. So for reasons that we don't fully understand, your antibodies start to react to proteins that are found in the kidney. And over time, they can cause kidney damage. There are some treatments available. I know there's treatments for IgA nephropathy. Although there's no specific treatment, there's certain things that can slow the progression of it. IgM, I'm not quite sure because it's relatively new, but I would suspect the same type of treatments could help. And as with all kidney diseases, it's important in that situation that you have very good blood pressure control, so less than 120/80, not good enough, but like good. Avoid certain nephrotoxic medications, as I alluded to earlier, things like Advil and Tylenol. Drink lots of water, exercise, control your weight, because obesity does cause kidney disease to progress more quickly. And smoking, any use of tobacco greatly accelerates kidney disease. And one thing I want to mention really quickly, because I just think it's so amazing, is how rapidly genetics testing has gotten cheaper. I mean, the Human Genome Project was completed in 2003, and it cost $2.7 billion to sequence one human genome. Now, 17 years later, we can do it for $349 or less. It's just amazing. It's actually improved much faster than computers. Like, we always talk about how amazing it is that computers have gotten so much better and so much cheaper, but actually genetics has advanced about 5 times more quickly than computer science, which just gets me so excited about what the next 10 years are going to see.
Thank you, Dr. Phil. Another question from Suzanne. My daughter was diagnosed with IgA nephropathy. Neither parent has it. However, I've had a kidney transplant 3 years ago due to high blood pressure. My mother was diagnosed with interstitial nephritis and received a kidney transplant. Should my daughter get genetic testing?
So let's see. So diagnosed with IgA, kidney transplant 3 years ago. Yeah, I would say it may be a good idea because it's not clear that, well, let's see. So the daughter has IgA. I'd have to think about that a little more, and I probably shouldn't be giving medical advice on this in this forum. But I would say that if you're not sure why someone has chronic kidney disease, then you should definitely get the genetics panel. Now, if your physician has given you a clear diagnosis and that diagnosis is not associated with a known genetic variant, then I don't think it would be necessary.
Thank you. Our next one is, I had IgA nephropathy for 20 years. My daughter donated her kidney 2 years ago to me. Is she a good candidate for genetic testing?
Well, she probably should have had genetic testing before she donated, although again, IgA, we don't know if there's a strong genetic component to IgA nephropathy. It's unclear. Whether she should get genetic testing now is a little bit tricky because she's already donated. So that would, I would have to know more about the case. What do you think, Trudy? I should let you handle some of these too.
Yeah, I think it's hard to answer some of those questions, without that full family history. But I think anytime you have a family history, that's definitely one of the, earlier onset, family history, atypical presentation. Those are all things where it can't hurt to get a genetic test to get more information, right, about certain findings. There's a lot we don't know, and sometimes we don't know what we don't know. And like Dr. Phil was mentioning earlier, with unknown etiology for chronic kidney disease, in some studies, 17 to 30% of people were found to have a genetic cause. So, there's a lot that's kind of just unknown, whether or not somebody should or shouldn't have a genetic test. I think a lot of it kind of depends on your history and how you're feeling about that.
Thank you. One of the things too, I just want to mention to everybody, please put your questions in the Q&A. We'll get to the ones in the chat, but it's we're getting quite a few. I think it's pretty clear if anybody has IgA nephropathy, they should get genetic testing. Would you agree with that? There's a lot of questions on that.
What do you think, Trudy? I mean, I kind of mentioned this earlier, but we're not sure that there is a strong genetic component to IgA, but if you're not sure, it's probably better to have the test. Go ahead, Trudy.
Yeah, I think just to add to that, so all the genes on the Renal panel are what we call monogenic. So meaning there's one gene and it causes one condition. With IgA nephropathy, there may be other kind of risk genes, or maybe some things that kind of make you more likely to develop it. But that's a really hard thing to do a genetic test for, because it's kind of like an additive effect. So the genetics of IgA nephropathy is oftentimes more complicated than some of the conditions that are on this Renal panel.
We have a question from M. Brandall, 55. How does genetic testing improve the rejection risk in kidney transplant?
Yeah, that's a good question, and it's complicated, but there's two things. So first of all, rejection is a very specific word that means when your immune system attacks a kidney, but there are other reasons kidneys can fail post-transplant, and many patients call that rejection also, although technically it's more like the original kidney disease comes back. So genetic testing can help with that, because as I presented in the second case, there are some types of genetic kidney diseases that can come back very quickly after the transplant. And if you don't know you have that disease, you may not get the proper treatment and you could lose your transplant, although that's not technically rejection. And then the second part to that answer is, we are expanding this panel. We are going to add more genes. And one thing we're thinking of adding, we're not sure yet, is it does turn out that patients metabolize the anti-rejection drugs quite differently. And patients that metabolize them very quickly may be at higher risk for rejection because they're not given the proper dose. So we may add on the second or third version of the panel some of the genes that can help determine whether you need higher doses of anti-rejection medications or not. And if you are one of those people, then yes, the genetics panel will help you reduce your risk of rejection after transplant, because it will let the doctors know that you need more of the medications than other people.
Thank you. Our next question is for Trudy. There's a question from Julie Hogan. Will this test be able to find unusual mutations for PKD genes?
Yeah, so this will look for all mutations in PKD1 and PKD2. It also looks for other mutations in other genes that could cause things that look like PKD. And then it will tell you which mutation it is and how that affects the gene. So and what we know about PKD1 is there's a lot of different mutations in PKD1 that cause PKD. So it'll look at all of them from beginning to end and like give you that information.
Oh, another question is from Carmen. Our little one was diagnosed at 5 weeks of age with kidney stones. He has passed 2 stones, but continues to produce stones. We don't know why this is happening. Would it be a good candidate for genetic testing?
Yeah, absolutely. And, we didn't cover kidney stones in this talk, but there are many genes on the panel that are associated with kidney stones. And for a child at such a young age to be having such a problem suggests that there's a strong likelihood of a genetic diagnosis. And sometimes this is a kind of genetic diagnosis for which treatment is actually available. Some of the genetic disorders associated with stone formation can be treated with a variety of medications and or diet. So yeah, I would say he should definitely have genetics testing.
This is an interesting question from Barb Westhoff. She says, what about somebody who donated in the 70s and now has anemia and doctors can't seem to raise it in 2 years? I mean, there's really no relationship to anemia to genetic testing, because it could be, or could it be there's something going on with the kidneys that produce the erythropoietin stimulating hormone?
Well, first of all, is this Pastor Westhoff from Montana? Because if it is, I know her. But so let's see. So someone donated in the 1970s and has anemia. I'm not sure there'd be a genetic cause for that. So I would have to defer on that one. I would ask your physician for further discussion.
Okay, one from Brian, daughter diagnosed with PCOS. Guy put her in metformin. I believe her first cousin diagnosed at a young age. No overt symptoms, though, except perhaps weight gain. Does have cysts on kidneys. Genetic testing helpful at this point?
So does she actually have? It doesn't seem like she actually has kidney disease other than having cysts on the kidney. And she had, yeah, I would say genetic testing is a good idea because it's possible she has polycystic kidney disease. So she should have a genetics test.
Okay, so let's go for this one. D. Dunaway. 50 years ago, I was diagnosed with ADPKD using the diagnostics available in 73 based on the I'm not reading very well, nephrotomogram testing, and their father had PKD. I'm on the transplant list and on dialysis. What advantage would there be for me to have genetics testing at this stage?
You want to take that one, Trudy? I think it's your turn.
I'm not sure I'm the best one to answer.
Okay, well, I can take it.
Go
So one thing we found is that a number of patients with polycystic kidney disease actually have second mutations that can actually change our understanding of their disease. So it might be helpful, but the fact that you don't have children who could then undergo their own testing and the fact that you've already progressed to end-stage renal disease suggests it would be more something that you would want for your own information and not that would influence your therapy.
Okay, thank you. I know you typed this answer, Trudy, but do most physicians and nephrologists know how to interpret and know how to apply information from genetic testing?
Oh yeah, I was just typing. I was saying some are more comfortable than others, and this is where Natera can help provide resources to both the provider and the patient. You know, some providers have been doing genetic testing for a while and feel very comfortable and knowledgeable about it, and others are maybe a little bit less familiar. So it might be more of a learning curve. But you know, what's been really what I thought was really exciting and kind of novel was a lot of the nephrologists that we talked to said, you know, where you really need to go to get genetic testing done more often is to patients, because the patients will come to us and tell us what they want, and they will learn from you as well. So that's one of the reasons why it's such a privilege to also be here today, because we feel like we're actually doing what some of your doctors have told us to do, is to help you as the patient, you know, formulate the questions and the for your provider to get the testing that you want.
Yeah. And let me add to that as a nephrologist. So, you know, my genetics training in medical school was a 2-week course, and it mostly focused on certain discrete genetic disorders. And remember, when I went to med school in the 90s, we hadn't even sequenced the human genome yet, and doing genetics testing just wasn't done. So many nephrologists haven't received a lot of training in genetics. So what we are doing about that, and we've already mentioned this, but we do have over 50 board certified genetics counselors and also medical geneticists and medical directors. So we are always available for the ordering nephrologist to talk to help them understand the test results. And when we talk to nephrologists about this test, we mention, hey, if you're not comfortable with genetics testing, you know, we're here to help. And then the second thing we're doing is we are doing a program we call the GIFT program, where we're actually going into training programs for nephrologists called fellowship programs, and we're giving them 1-hour talks on renal genetics so that they can understand this. So I suspect the younger generation of nephrologists, younger than me, are going to be much more up to speed on genetics testing.
Thank you, Phil, Dr. Phil. Can you guys go through the some of them have already been answered, but just to recap, there's a lot of talk about, you know, their kids having chronic kidney disease. This one is my 12-year-old son has chronic kidney disease that they said his Crohn's is attacking his kidneys. He is in stage 5. Would a genetic test help find out more?
Yeah, I would say yes, because he's a young age, and he has a disease, tubular interstitial nephritis, which can have a genetic cause. And it may be associated with the Crohn's disease, but if it was my kid, I would want to know for sure. I would want to leave no stone unturned, and I would definitely want this panel done.
There's a question from Patrick Jones. I've had 2 failed transplants because of FSGS reoccurring. Is there any hope for me? I'm 42 years old and currently on dialysis. And yeah.
Yeah, I'm not sure how genetics testing would help, because genetic causes of FSGS tend to not come back after transplant. So the fact that the FSGS came back after transplant suggests that there's not a genetics cause. Now, there's always hope. You know, we've made a lot of advances in the last few years, and I'm confident one day we'll know how to prevent FSGS from recurring. So don't give up.
Here's a question from Julie J. I have recently been evaluated for a deceased donor kidney transplant. I just realized what that acronym is, and am on the waiting list. My nephrologist ordered a kidney biopsy in November of 2019. I am wondering how best to request genetic testing. I mean, can you maybe make the connection about biopsies and genetic testing for transplantation?
Sure. I'm trying to find the question so I can see it again. Well, so the easy part is the best way to get genetics testing is to talk to your nephrologist about it and just say, hey, I heard there's this new renal genetics panel. A lot of nephrologists are using it, and I'd like to ask you if you think I would benefit from that. And as far as the linkage between the panel and biopsy, so often the panel can avoid a biopsy, but even because if you have a genetics diagnosis, you may not need a biopsy. But even if you do have a biopsy, understanding the genetics can actually change how this biopsy is interpreted. And the example we gave in case number 1, this patient did have a biopsy which showed FSGS, but when he had genetics testing, he discovered he had a different kind of FSGS that doesn't respond to treatment. And you can't see that on the biopsy. You only can get that information through genetics testing. So even if you've had a biopsy, there may be benefits to genetics testing, although it will depend on what was specifically found on your biopsy, and you'll have to discuss that with your physician.
There's a question from Mihi. She's basically asking if a family member, if she has kidney disease and wants to know if her family member should have genetic testing, and is there anything specific to qualify to have the test done? I guess your doctor has to make that decision.
Yeah, Trudy, you want to take that one? I think it's your turn.
Yeah, there's really no, it's a great question. Like what bar do we need to pass in order to kind of earn genetic testing or be qualified? And there really isn't anything that says you have to have X, Y, or Z. It's definitely a test made for people with kidney disease. So I think a healthy person would not benefit from Renal unless there was a genetic disease in the family and they're being worked up for donor status. But in general, if you have concerns or questions and you want to talk to your physician about it, I think that's where you start. Everybody's history is a little different. It's hard to say, but if you think about 10% of kidney disease has a genetic cause. And the things that might make it more likely to be genetic are earlier age of onset, family history, more severe presentation. So all of those things make it maybe higher than 10% in some people, or if you don't have those things, maybe it's a little bit lower, but everybody has a risk that they could have a genetic cause for their kidney disease. And I think one of the things also, this testing is relatively new, right? We just launched Renal in May of last year, and it's one of the first really broad panels like this that's available. So we don't know all the things we don't know about who should have testing done. And so my bias is if you think this is information that you would like, it doesn't hurt to get the test done so that we can learn more. And then maybe in a year from now, we'd know, if this is what you have, this has been the experience that we've seen, and be able to provide that kind of data that we don't have yet.
Well, thank you so much, Trudy. I mean, we're coming to the end. If you want to go through the chat and see any questions you could answer, just type to them. That would be wonderful. I think that it's been a really wonderful day of information, and You guys are so knowledgeable. I mean, I have a little short story. I did the 23andMe last January and found out who my father was. So another level of genetic testing. So we're learning so many things. And every time I run into somebody, I hear another story of like, yeah, we didn't know we had a family member. So there's going to be no secrets about us in the future, right? I mean, we're going to know everything by genetics. Do you guys have any closing thoughts before we wrap up?
Yeah, one thing I want to mention quickly, because it comes up a lot, and I think I saw it in some of the questions, is, if I have a genetics diagnosis, does this affect my ability to get insurance? So there is a law, Genetics Information Non-Discrimination Act, GINA, which specifically says you cannot be discriminated against for health insurance or employment on the basis of a genetic diagnosis. Now, what's really interesting about that is that doesn't cover any other kind of medical diagnosis. So for instance, if you have a kidney biopsy and it shows you have a horrible kidney disease, then theoretically, you could be denied health insurance or employment. So it's actually better from that perspective to have a genetic diagnosis. Now, the law does not specify anything about life insurance, disability insurance, or long-term care insurance. So if those are concerns, you'll need to discuss that with your physician when you're talking about ordering the test. And that's my last closing statement, other than to say thank you again for your attention, and I hope everyone has a great rest of their weekend.
Thank you.
And I did put a link to a really great website from the National Human Genome Research Institute on GINA in the chat if anybody wants to read up on that themselves, because I know that is a common concern. So.
Perfect. We're going to email everybody who's participating, and we'll definitely put that in the follow-up email. That will go out on Monday, everybody. And then your free gift will be that you chose will go out next week as well. I think the mail's a little faster nowadays after the holidays, but on behalf of RSN, thank you for sharing your knowledge and expertise. And I'm so glad that we had such a great turnout and people, wanting to learn about, the causes of kidney disease and how they can help navigate their health. So with that, thank you so much. And I guess we can go enjoy the rest of our day.